C'est un très grand plaisir et un très grand intérêt d'inviter et de vous faire écouter le professeur Lars Stegger, qui est chef de service du service d'imagerie multimodalité, puisque c'est l'intitulé de son service, et de radiothérapie vectorisée du CHU de Münster. Le professeur Lars Stegger va se concentrer sur les indications tumeurs primitives osseuses avec les différents problèmes d'agressivité, d'évaluation initiale d'une tumeur d'origine inconnue, de nature inconnue, ostéo-osseuse, avec l'agressivité, les incidentalomes, les bilans d'extension, et également le retour d'expérience sur les métastases osseuses de cancer ostéophile dont on a discuté plus avant. C'est Dept.
Oui. Merci.
Alors, en anglais.
Merci beaucoup pour l'introduction. Comme Dr Péchard a already dit, ma commande de la langue française n'est pas assez bien pour être capable de présenter en française. Vous avez le choix allemand ou anglais, mais je pense que l'anglais peut... je vais continuer en anglais. Topic. I'll just give a very brief overview from PET to PET-MRI, where we have come to. Then I would just like to give you some general considerations of PET-MRI imaging versus PET-CT imaging, and then I would give you some examples of imaging of bone metastasis with PET-MRI, and a bit more briefly primary tumors in PET-MRI. So start with the first one, of course, just to give a presentation. There is, of course, a lot of people we are indebted to for our present topic of PET-MRI. The detection of radioactivity by Henri Becquerel is very important. Then the invention of the tracer method by Georges de Havilly has been very instrumental for our subject. Then the detection of the positron is important in 1933. That won the Nobel Prize for Physics for Carl Anderson. Then, as we've already seen today, the first clinical positron scanner at the MGH in 1952. And I also think that was the first PET scanner also in Boston in 1971. Of course, we know that our methods of nuclear medicine are very good in achieving a very high molecular sensitivity, but they are not very good in depicting anatomy and function. So it's very natural to combine the methods, or combine our methods, with computer tomography and magnetic resonance imaging in hybrid devices, and that is exactly what has been happening in this millennium. We first had the SPECT-CT very early in this millennium, then the PET-CT was introduced for clinical service in 2001. Then it took a few years of development, basically prototypes of small animal PET-MRI, to really reach the status where you could use PET-MRI in humans. 2008, there were few prototypes around for brain PET-MRI, one in Tübingen and also one in Boston. And starting from 2010, it was possible to really use PET-MRI for clinical routine imaging. So, what I would like to focus today is what might tip the scale in favor of PET-MRI versus PET-CT, because PET-CT is really, I think, a brilliant technology and a brilliant technique, and is very widely used in oncology, but also in cardiac and neurological imaging. But especially for oncology, PET-CT has really had a large impact on clinical imaging, and I have to say it's an accepted and very good methodology. So in order for PET-MRI to replace PET-CT in whole body imaging, PET-MRI really has to bring some advantages to the table and to be really better than PET-CT in several respects, because otherwise PET-CT is relatively cheap, it's fast, it's convenient, and it's established. So PET-CT, as you all know, has really very quickly replaced PET and CT separately. If you look at the numbers, 2001 it basically was introduced in the market, and just look at this one. This one is the curve that gives you the proportion of all PET scanners that were indeed PET-CT scanners. And within very, very few years, PET-CT has replaced standalone PET completely. And so the market penetration was very high because, everybody wanted to have PET, even though you could also look at PET images and CT images and could, in the most cases, come to the same conclusions in terms of clinical performance. But why has PET-CT really been so successful so quickly? I think it's because of very favorable patient logistics, and in Germany the situation is slightly different. We do 80% of all scans, we do diagnostic CT with contrast agent, so the patient has only come once to the imaging center, and also then all the referring physicians get an integrated image interpretation. That in our case we always do it jointly from nuclear medicine and radiology. And it's not too difficult if you compare it to PET MRI. CT images are more straightforward than to master MR imaging, which is a very complex topic. And of course, PET has also advantages in having a good or optimal spatial co-registration. As you know, it's not really a perfect temporal co-registration because you can't image the same field of view simultaneously, but rather sequentially. But still, the patient is in the same bed and you get much, much better spatial co-registration with PET-CT than with standalone machines right after another. So now if we go to PET MRI, if we combine PET with MRI, there are certain advantages or theoretical advantages. First, you can have more and different information. With MRI, you can have more information about soft tissue, liver, bone marrow, gives you better contrast as opposed to CT. Of course, you also got disadvantage that MRI is not very good in depicting really bone structure, except for, say, very fast TE sequences, but they are not overly useful for diagnostics. It gives you better vessel imaging than CT. You can have perfusion, diffusion. You can look into metabolites and so forth. So MRI can give you a lot of different pieces of information. In comparison, CT is rather limited at that. Of course, it uses less ionizing radiation, and if you look at rather old data from this generation of PET-CT 2005, you see that the most part of contributing part of radiation actually stems from diagnostic CT versus PET, and this one is for 370 megabags FDG. Today we use less, so the contribution of PET is relatively low. Low dose CT makes it better, but of course doesn't give you diagnostic information. What is really the very, very novel and very good aspect of PET MRI is really that you have a very perfect temporal co-registration that you don't have with PET CT. That gives you the option in really looking from PET and MRI in a patient in a situation that is changing, that is time dependent. For example, if you do an intervention, cardiology, for example, you give a stressing drug, for example, or you give a drug during neuroimaging. That is really, you can do really unique things with MRI. Or what you also can do is, for example, you can do motion correction. If you look at motion, you monitor motion by MRI, you can use this information to improve PET imaging, as we've already seen before. So for bone malignancies, we have in Münster a lot of patients with prostate carcinoma, so bone metastasis is an issue in Münster, and to a lesser degree primary bone cancer, because even though in Münster we have a lot of patients with a Ewing sarcoma, our pediatric oncologists still were very in favor of PET-CT, and we are gradually starting to image these patients on PET MRI. So if you look at PET MRI, we have seen before that there is a lot of things MRI can do that CT cannot do, but we also have to consider that the traditional use and the strengths of the things of PET and MRI are working essentially on different scales. Where PET is a whole body imaging application, in most cases of cancer and inflammation, and covers rather normally a large area of the body, and is less often organ imaging. You could have that in brain, but in heart. But for cancer and inflammation purposes, we always do whole body, or essentially, almost whole body imaging. The only deviation in Münster is if we look for benign changes to the parathyroid gland that is not detectable in SPECT CT. We only do cervical and chest imaging, but that's the only exception. So MRI has different strengths. The real strength is to look at a very, very small part of the body, but very much in depth. Small, with a good resolution, with different plane orientations, with different contrasts. This is really where MRI excels and can give you a very, very good impression or information on this body part. So that is what I call narrow. So it depicts a small part of the body, but very in-depth information. Whereas whole body MRI is possible and people are doing it, but you sacrifice a lot of the potential that you have by MRI. So that has compromises. It covers a large part of the body, but the information that you get is more shallow because information in depth takes time. So in order to scale this one up, same depth of information in a wide area of the body would just take too much time to complete. So that means that when you look into whole body PET MRI protocols, you have to have compromises in your MRI sequences. For brain and cardiac, there are less compromises, so that is why a lot of people think that PET MRI is more suitable for brain or cardiac applications, and whole body applications is a bit more of a struggle to really convey the information that PET MRI is also useful there. So what are we doing in terms of imaging? We have standard whole body sequences. We almost always do a T1 native scan. We do a T2 scanning, and that we do concurrently with the bed positions in PET. We also do post-contrast imaging with transaxial images after PET, and depending on our question how much time we have, we also do coronal imaging with the standard sequences. If you look, for example, in bone, and especially in bone metastasis of prostate carcinoma, we have seen that there are additional sequences that might help us in finding lesions better than the standard sequences. For example, in the pelvis, we have these additional high-resolution sequences in the coronal orientation. The T1 turbospan echo with a high resolution gives the information, and the T2 also term that suppresses the signal from fat. We also use in this orientation, and then for the lumbar spine, we also use sagittal-oriented images, also high resolution, the same as above. So that adds about, I think, roughly 50 to 20 minutes to the whole examination, but gives us more information in finding MRI tumors in or metastasis in the most prevalent regions of the pelvis and the part of the vertebral column. So what we also do, and that is relatively fast, you can also do diffusion imaging. This diffusion and the ADC map that you calculate. This is a Ewing sarcoma image, but you also can do it quite efficiently also for if you do whole body imaging for metastasis in the bone. So if we now go to bone metastasis, I would like to present you some items from the literature, where people have compared PET MRI to PET CT and the performance of PET MRI in detecting bone metastasis. All the studies published so far are relatively limited in scope, so they are not For example, you can see it in the numbers. There are, for example, not studies that really compare hundreds or thousands of patients. One of the first studies from Essen, one of the places in Germany who had the scanner very early, much earlier than in Münster, they just went for the assessment of bone lesions in oncological patients. You can see here it's FDG, so it's not prostate cancer. You can see that there is a variety of patients that were scanned, and these are actually the patients where they found bone metastasis. Altogether it was 67 patients. They used CT with contrast, so diagnostic CT, and they compared it to more or less standard whole body MRI sequences, including diffusion imaging. As gold standard, they used histology or follow-up, and what they were able to see is that PET MRI was better in depicting malignant lesions. But if you were looking into benign lesions, then it was different. PET-CT was very much better suited to rule out malignancy, to look at the features of benign tumors and really determine that they are benign. So when going from PET-CT to PET MRI, you have an advantage in being able to better spot malignancies, but at the expense of being less able to differentiate benign lesions or to spot benign lesions. So PET MRI seems to be better for malignant than for benign lesions in this study. And this is what they did. They looked into the diagnostic confidence. 1 is certainly benign, to 5 certainly malignant. And if you look at PET-CT, and this one is the confidence in malignant lesions, they were very confident in both cases, but slightly more in PET MRI that the malignant lesions were really malignant. But you could see 1 is certainly benign. PET-CT was, or the diagnostic confidence was much better in PET-CT as in PET MRI. So PET MRI, it was more in the area of probably benign or indeterminate, but certainly benign, the number was much lower. So PET MRI, again, better suited for malignant than for benign lesions. What MRI is good for is, for example, if you have a lesion that doesn't really have a lot of uptake in FDG imaging, and this is one case from the same publication. They have one in adenocarcinoma of unknown, with a primary of unknown origin. They was able to spot a metastasis in the L2 column with only very slightly increased FDG uptake, not really visibility in CT, but very good visibility either in T2 imaging and also in diffusion imaging. So that is probably one of the best advantages of MRI as in combination with PET to really spot lesions in the bone marrow. So MRI may reveal metastasis with a little trace affinity, as you can see also in the next slides. So there is another study from Munich. Also, I think they were the first in 2010 who got a PET MRI scanner in Germany, and they also did something similar. Same here. They did loaded CT versus MRI, but also standard MRI sequences, and they tried to find out whether they are better in CT or better in MRI. And the diagnostic confidence for the malignancies was slightly better in MRI, so higher means better. Yeah? But it's not really a very vast difference, but it's a slight difference. So MRI offers slightly better delineation capability than CT. What they have done is they've basically taken the lesions that were visible in MRI and see whether anatomic location and delineation was in CT or MRI better than in the other. So not, for example, having an independent measure or gold standard of lesion, but rather looking into the PET visible lesions and then look at the corresponding anatomic the anatomic orientation. So that is one study. They didn't look into FDG, but rather fluoride. It's very, very current. still not published in writing, so it's online first. And they compared in 117 patients prospectively, but only 47 for PET MRI, the following: bone scan plus minus PET-CT, then sodium fluoride PET-CT, and sodium fluoride PET MRI in a subset of the patients. Those were mainly breast cancer patients, prostate cancer, and one renal carcinoma. And what they found is bone metastasis in 16 patients. There were different than in the other studies. They found that it was less equivocal patients when using PET MRI versus PET-CT. And PET MRI also had the highest sensitivity, also in comparison to PET-CT, but a slightly lower specificity than that. But this is even more current. There was a response. So MRI, PET MRI, not significantly better than PET-CT, sensitivity better, and also the diagnostic confidence was better here than PET-CT, but not really very much better. There was one letter to the editor as response. It is September 15th, and they say bone marrow, or not bone metastasis, is what the 21st century diagnostic imaging must focus upon when looking for skeletal metastasis. And this is exactly what we are doing, and what the strength of PET is versus PET-CT, that you're really looking at a feature of tumor, for example, taking up more glucose or binding to a prostate-specific membrane antigen that is better than only looking at the response of bone formation that both sodium fluoride PET does and CT and bone scanning does. So this is just something that I also would think that is important for us. There's one study that looked into prostate cancer. Now we come from FDG to PSMA, rather novel ligand that binds to prostate-specific membrane antigen, which is not prostate-specific at all, but it's still named that way. So that is something you have to keep in mind, that is not prostate-specific. And they compared also PSMA PET MRI in comparison to PET-CT. Also a very, very, very low number of patients. If you are very early, you can do it in very low number of patients. PET-CT versus PET MRI, and also very, rather standard whole body PET MRI sequences. They found in these patients